Welcome, everybody. Thanks so much for joining today. This is Dystroglycanopathies, Ask the Expert. And I'm going to share a couple slides just to get us started. Today, we're going to meet our experts, and then we're going to go through some research questions, followed by care questions, and then a few closing remarks. And we're going to meet our experts in just a moment. Kathy, would you like to introduce yourself?
I'm Kathy Mathews at the University of Iowa. I run a natural history study together with Dimah on dystroglycanopathies in general.
Dimah?
Hi, I'm Dimah Saade. I'm at the University of Iowa. I work with Kathy Mathews. I'm a child neurologist.
Chiara?
Hi, I'm Chiara Manzini. I'm a geneticist, so I try to figure out what are the genetic causes of dystroglycanopathies, and then we develop models in zebrafish. So we put the mutations in zebrafish to try and compare what the different genes do.
Rich?
Hi, I'm Rich Kravitz. I'm a pediatric lung specialist and sleep specialist at the University of Virginia, and I'm working in our neuromuscular clinic where I see patients with all different types of muscle weakness problems and the pulmonary consequences.
Thank you. Reghan?
Hi, I'm Reghan Foley. I'm a pediatric neurologist, neuromuscular specialist. I'm working at the National Institutes of Health, and our team has a focus on congenital muscle diseases.
Carsten?
I'm Carsten Bönnemann. I'm a pediatric neurologist, physician scientist, and very recently also at the National Institutes of Health, working with Reghan Foley. But a couple of months ago, I moved to St. Jude Children's Research Hospital as chair of a new department on genomic and translational neuroscience in order to advance genetic therapies for congenital muscle disease.
Thank you. Gus?
I'm Gustavo Dziewczapolski. I'm the scientific director at CureCMD.
And I'm Rachel Alvarez, Executive Director for CureCMD. All right, Gus, take it away.
Okay, so to be all in the same page, can you briefly describe the massive spectrum of alpha dystroglycanopathies?
Do you want me to start that one?
You can, Chiara also.
So the dystroglycanopathies they share the feature that a protein called alpha dystroglycan lacks normal amounts of sugar groups put on it. And this can cause anything from a relatively milder form of muscular dystrophy with onset in adulthood to through a full spectrum, including infants who are born with muscular dystrophy and weakness. And those infants often also have involvement of their eyes and brain due to the same underlying problem.
Anybody has something to add? Oh, how many genes we know now?
Yeah, so maybe I can
dystroglycanopathies?
add a little bit on the genetics, because there are multiple genes, and as Kathy was saying, most of them are involved in the attachment of these sugars on dystroglycan. And actually, Kathy in the past has represented the sugars as like the arm coming out of the body to grab to things. And so there are enzymes that will attach the shoulders, enzymes that will connect other pieces, and then the ones that will make the part that grabs to proteins outside the cell. And then there are enzymes that make the pieces, the sugars, that have to go and build this entire structure. And so one of the big difficulties has been trying to figure out, are all of these genes doing the same thing, like causing the same type of disease, or not? Is it the type of genetic mutation that causes more severe or less severe disease? Or are there specific genes that tend to cause more defects in the brain and in the eye? So one of the problems with dystroglycanopathies is that this protein, dystroglycan, has a very important function in the muscle, but it also has a very important function in how your brain is put together, in how your eyes are put together. And it does this function slightly differently in every single tissue during development. So a large part of our work has been looking at the more severe dystroglycanopathies, and we have an article, a new scientific article that we're going to be putting out that shows that the attachment is really critical for the brain and eye, but also trying to look in multiple animal models, all the same in comparison with different levels of, with different genes to see whether there are specific differences in these genes, because this is going to be really important on whether you decide to do individual gene therapy for every single gene, or whether you can try and group people together for a similar approach. And I think this may come up with the ribitol questions.
Yes, thank you. And actually, the next question is about ribitol. That is the one of the treatments that is on clinical trial right now. The question is if you can provide an update of the status of the ribitol clinical trial, and also because we know that the current clinical trial is for 12 years old and over, and is for LGMD2I R9. But if this treatment is an option for congenital alpha-dystroglycanopathies. So an update on the ribitol clinical trial, and if this can be used for pediatric cases. Maybe Kathy.
So, as you said, the clinical trial is let me back up. The principle of the ribitol trial is substrate loading. Basically, you have an enzyme that isn't working well enough to make the long sugar chains, the long arms. Good thing I have a big enough screen, I can show my arms. So the enzyme works a little bit, but it doesn't work enough. The concept is that if I put in a bunch of the stuff that the enzyme works on, I can make that enzyme work harder and add more sugar chains, and thus mitigate some of the disease. So that's the principle. The results that have been presented publicly at the MDA are very promising. It looks like the principle works and that there is benefit compared to placebos. The principle of, so ribitol could work for theoretically anybody who has residual FKRP activity, but an insufficient FKRP activity, anybody who has insufficient ISPD activity, but has some activity, and anybody who has insufficient but some Fukutin activity, FKTN. So those three could potentially benefit from ribitol. And because it is a sugar, that's a substrate loading, it's a sugar, it could theoretically work in younger children, but we just don't know for sure doses and side effects, so it would have to be studied. The concept of substrate loading could work for many of the other dystroglycanopathies because they are enzymes. And so if we identify and can formulate a sugar that will work with that enzyme, the concept could work and is an exciting option for congenital muscular dystrophies due to dystroglycanopathies.
Yeah, as you mentioned, I had at the MDA meeting after the update. I had a conversation with some of the medical advisors at the company, and they told me that they need to get the approval for the population that they are testing right now, and then they will like to move to the pediatric cases.
There are several of us who have been talking to them for a number of years also about the Fukutin and ISPD.
Perfect. Great. Okay. So we will keep advocating for that. So you already mentioned that this is a possibility for other genes too, if we identify the sugar precursors needed for that. That was the question that was coming. So it's already addressed. So we can move now to gene therapies. The next question is if you can mention what advances have been made in gene therapy approaches and which causative gene is the farthest along in therapeutic development. The person asking this question has particular interest in POMT1, but I want to generalize this.
Let's start, Carsten.
Yeah, so in general, gene therapy is an attractive therapeutic modality for the alpha-dystroglycanopathies because with one possible exception, they are all recessive, meaning they're loss of function or reduction of function of the genes. And secondly, most of them are small in terms of what you have to deliver to augment the gene activity. So they fit into the current workhorse of gene therapy, which is adeno-associated virus or AAV. And the last kind of point to make them very attractive for gene therapy is that most of them are enzymatically active. So they're kind of glycotransferases, they're enzymes. And in biology and then in gene therapy, that actually is a good thing because increasing enzymatic activity by just a bit often goes a long way in correcting biochemical disorders. And it's different from, for instance, structured proteins or maybe like in the Duchenne muscular dystrophy, where you have a large structured protein that doesn't even fit into AAV. So there you have kind of two strikes against you. It's too large for AAV, and it's a structured protein where you probably have to deliver more efficiently to kind of correct the disease. And so in the alpha-dystroglycanopathies, we don't have that problem. We have a small gene that fits into AAV, and probably just getting a little bit on target will go a long way. So that's very attractive about it. What's unattractive about it is from a drug developer perspective that there's so many of them that you have to do. And so in gene therapy, it is a platform, if you will. You deliver something to the target, but each cargo that you deliver has to be the specific gene in question. And so the winner just by numbers has been FKRP, which is kind of the most common of them. And that's the reason why that moved into gene therapy into humans. First, I believe there are two trials, Atamayo and AskBio. There may be more in the pipeline, but those are the ones that are currently dosing in patients with kind of a narrow inclusion criteria. So none of them is severe congenital. I think they're mostly the LGMD variety of it. Now, having said that, that I think is a big important proof of principle. If that kind of has an effect and goes somewhere, then you could make the point. Now we have a concept established, and maybe the pathway for ultra rare conditions in dystroglycanopathy is going to be easier. And POMT1, of course, the gene in question here, is an attractive candidate for gene therapy, but it is much rarer. So one has to kind of come up with an alternative pathway to getting gene therapy done in this patient population that is not probably purely commercial, because the numbers don't add up for a company, but in partnership, I think, between advocacy, industry, academia, I don't see a principal reason why that shouldn't be pursued at some point.
And maybe I can add, since I now work primarily on POMT1, what has been done at what it's called the preclinical part, so with animal models, to try and figure out if like the reintroduction of the enzyme is even feasible. And there was a very nice paper from Kevin Campbell's group on the POMT1 knockout mouse, which is basically a mouse that has POMT1 taken out, where they used AAVs, and so the viruses that you could use for gene therapy to reintroduce it in the muscle. One of the issues with POMT1 is that you will also have brain, you will have eye, you will have multiple tissues affected. And so what we're trying to do with our fish is also, because in the fish it's relatively easy to put things back in like different tissues, is try the relative rescue in different places. And then that's the strategy is going to become a little bit complicated, but now there is gene therapy for the eye available. It's probably the easiest in gene therapy in general for eye disorders, not for these particular disorders, but that has been validated. Gene therapy for the muscle, for Duchenne muscular dystrophy. There's gene therapy for the spinal cord, for other disorders. And so I think there is a lot of excitement in the field. The problem with this type of disease that affects multiple tissues, like how do you hit them all? And that's going to take a little bit more of preclinical work, because if the muscle was difficult, the brain is a whole other it's
Yeah,
a
I mean,
whole other level of
yes,
trying to get to it. So
yes, but as you pointed out, there are hopeful new technologies that are emerging, in particular in capsid engineering. So AAV, in principle, AAV is an envelope with a cargo, and so the envelope we call the capsid. So that's kind of the protein surface, that kind of the envelope really where our therapeutic cargo is being packaged into. So that envelope is really, really important to get to the tissues of interest where we need to deliver our cargo to correct the problem. So that is a one-time thing. So it's a virus only on the surface. It infects, but it doesn't replicate. It just goes there and delivers the cargo. So that envelope is really important to find the cells and tissue of interest. So it really needs to find its address to be delivered appropriately. And thus far in gene therapy, we've used capsids that I call legacy capsids. Those are capsids that occur in nature, that nature has kind of developed to kind of use the AAV for what viruses do, which is just kind of replicate and then go on to the next. But there's now engineering of capsids to really make sure that they're home more precisely at lower doses, and that's been successful in the muscle field. So some of the, even in the clinic, are now using these new capsids that go to muscle more effectively. But the same development is also now underway for central nervous system targeted capsids, where the crossing of the blood-brain barrier could be possible with just intravenous application. The jury is still out on that, the safety is still out on that, but these are under development. There are different ones that are now being tested, including clinically. And that would then allow to get to more of the interesting targets for the disease. And there is, of course, when you have a severe POMT1 or severe congenital muscular dystrophy with brain developmental abnormalities, that is not correctable. That's something that has happened in development. However, there's an aspect to brain function or brain dysfunction, alpha-dystroglycanopathy, that may not be fixed or maybe modulable, and that is alpha-dystroglycan also has an important role in the synaptic connectivity of nerve cells, and that could play into the central nervous system phenotype, the behavioral and the neurological phenotype in children as well. And that aspect may be addressable with gene therapy. There was an interesting paper, I think, on POMT2, very related to POMT1, where in the mouse model, some of the neurological phenotype could be improved by delivering it there. So I do see a rationale to include that in the gene therapy.
Yeah, and I've seen some really cool in the intellectual disability and autism field. Now people are also looking at these exosomes produced by neural progenitors, which wouldn't even have a capsid, for delivery of DNA into cells. And so you basically take a very young neuron and take it's almost like now they're being talked about in skincare, the exosomes. because they deliver things they get into cells. And so there is a lot of preclinical development also in trying to find alternatives that are not viral, which again, as Carsten was saying, it's all still being tested. We have no idea about safety and efficacy, what efficacy could be in humans, but there is definitely a lot of research into trying to deliver genes into the brain and in tissues that are more difficult to access that hopefully will come to fruition.
Okay, so we have all these potential treatments in the pipeline, but the ones that are leading the gene therapy at the moment is the gene therapy for FKRP, right? Okay. And you cover most of the things that is if the gene therapy could arrive to both to muscles and brain. So and also that these genes are amenable to be treated as a platform technology approach. So let's move to this is kind of a very unique question because it's also one of the enzymes that is probably one of the latest that was implicated in alpha dystroglycanopathies. This is INPP5K. And there is a recent paper about the crystal structure, and one of the families asked about if you can comment on the implications of that study.
So I think I have to take this one because I'm the one responsible for putting INPP5K in the mix. And so first of all, INPP5K, I think, is dysglycanopathy adjacent, like the primary deficit that we saw in those cases is probably that dystroglycan couldn't make it to the surface of the membrane, and so it's a different mechanism, and it can be variable in the different kids. Like some people may have more dystroglycan distribution that doesn't fit into a dysglycanopathy, and some people may have this like membrane, this presence of the dystroglycan on the surface of the cell disrupted. And so that was a really interesting paper. And I actually had seen it when it came out because one of the most important things that you want to do when you study a protein is to figure out specifically how it's made and how all of its different components interact with each other. And INPP5K is also an enzyme. And so for the enzymes, you want to know how they function, where the substrate, so the thing that they work on, fits into the protein, because that's very, very, very important for figuring out possible drugs that can make them work better or they can make them work worse. So the really important part of that paper is that we have a good structure for the portion of INPP5K that the business portion of INPP5K. The particular paper looks at an inhibitor, so something that prevents INPP5K function. Because the mutations disrupt INPP5K function, that particular drug is not going to work because it's going to make it worse. But knowing that structure could be important to find different molecules that could make it work better. And so similarly to the ribitol, where you give more substrate to make the enzyme works faster, you could have a molecule that just makes the enzyme works faster on its own, which is called an agonist instead of an antagonist. So it was an exciting paper to see, and now some AI modeling should be done to identify like interesting molecules, which is there's a lot of AI applications on protein structure to identify drugs that fit into NOx.
Carsten, you wanted to say something? No?
I think I just said it, that's the important part, that, if you know the structures and there's some residual function of the protein, then you can really think about a small molecule that would kind of squeeze out more function out of the protein by binding to particular parts of the protein to make it more functional. And that is then a process that's now greatly accelerated by large learning models and artificial intelligence. So that's no longer science fiction. I think these developments can go much faster now. So that's a hopeful aspect of this.
Yeah, and I will add something about this paper because they demonstrate that the structure is not the same in the human protein compared to the mouse and rat. So that's also the need to find a better animal model. In this case, they find that a hamster is better than rat and mouse, but also I think it talks to the importance of humanize or making models that are humanized.
Or not animal models at all. Just kind of start with human systems, human cellular systems, and organoids. Yeah.
Yeah. Good. Okay. We need to speed up. So maybe one more question about research, and it's more kind of in between research and clinical care, because we can talk about natural history data. And the question is about what outcome measures and natural history data are most critical for designing clinical trials in ultra-rare and phenotypically diverse CMD subtypes like alpha-dystroglycanopathies.
Great question. We're trying to figure out what are the best outcome measures with such a very diverse group of patients and diverse groups of abilities. And I'm from a natural history standpoint, one of the things that is challenging is finding something that works in an infant and can also be useful in a 3-year-old and a 5-year-old so that we can actually describe and figure out how things change over time. We do have tools that have been used in other studies to actually measure function, other diseases, to measure function. And then biomarkers are always helpful. So tissues that come from patients can be helpful. I know we're working with Dr. Campbell's lab on trying to come up with biomarkers that might work across different kinds of dystroglycanopathies, and other groups are also doing that. So the biomarkers are signals that directly relate to function without actually measuring function. Other comments from other people?
Maybe just to add, that's so important that we do deep phenotyping of all organ systems. So as we've seen in other congenital muscle diseases that have gone into clinical trials, including gene therapy trials, we need to make sure we understand not just the muscle and obviously brain and eye for dystroglycanopathies, but also other organ systems that may have a manifestation that should be understood before we advance to a therapeutic intervention.
And the other thing too that I would add is possibility of grouping groups of people per phenotype category rather than splitting them up by genotype, because that could help enhance numbers and come up with natural history for specific phenotypes.
Is that the approach that you follow in your natural history study?
There's my unmuting the mic. So it is one of the aims of our current grant. It requires large numbers and a lot of sophisticated statistics to try to ensure that we're grouping people appropriately. We are developing, we're getting close to those numbers to be able to do those kind of analyses to identify groups that could potentially be studied together in a trial.
And is there any natural history study specific for the CMD forms of alpha-dystroglycanopathy, or it's just part of your large natural history study?
Just part? Crushed.
Sorry.
I'll let I don't know off the top of my head of another group focused just on congenital muscular dystrophy natural history studies, but others may.
The only thing that I know was that at CHOP, there's a congenital disorders of glycosylation. There's a very large congenital disorders of glycosylation natural history, and the dystrophicanopathy genes are included. Because we were talking to some of the families that have fewer cases, and it's just like, oh, that could be another source of trying to get natural history study done. The issue is that I think for the congenital disorders of glycosylation, they have like 90 genes now, and so they need to reach a critical number of cases where they will do this. But I know they were open because since this affects glycosylation, they just put every single glycosyl transferase in their list.
Kathy and Dimah, could you guys comment on what variables you're collecting in these natural history studies?
Takes 3 to 4 hours to get through an appointment. In general, we're collecting physical therapy, standardized physical therapy outcome measures. We're collecting either parent-reported or patient-reported patient experience outcome measures, largely from the NIH toolbox. We collect urine, blood, and we collect skin fibroblasts on everybody at enrollment who is willing. For those who are able, we do PFTs, MIP, MEP, sitting and lying. Richard, for you. The things we do not do as an experimental measure, we did an outcome study of ERG as a measure of eye function, and we're expanding on that. We saw a difference there. We're expanding on that as a potential outcome measure reflecting the retina. We are not doing, due to thank you, Rachel, breathing tests. We are not doing muscle MRI, which is a powerful tool, but again, because of money and time, we aren't doing muscle MRI, and we aren't doing cardiac studies as part of our study, but we are collecting the cardiac studies that are being done on a clinical basis locally.
Great.
We also collect brain
yeah, sorry.
MRIs that are available that are done on at local basis clinically.
Perfect. I think we should move to the questions more related to care now, and then if we have more time, I don't think so, we can come back to some more questions on research.
Okay. So my first question on care is, what are the key facts that we should be informing routine care providers like primary care physicians, pediatricians, people who are not at all familiar with dystrophicanopathy? Reghan, you want to start?
Sure. I mean, I think we always, I try to make sure that local providers know they're not actually, working in a vacuum. There's plenty of experts at their disposal as well as information, so they're not too afraid to proceed with the care of a child that's complex. Obviously, we also promote care for surveillance always of pulmonary function and cardiac function, even if there is no evidence initially of any cardiac or pulmonary involvement, because sometimes even in the same genetic subtype, some patients have cardiac involvement that may be observed over time, and so we have to be careful and have that surveillance. And the other elements, as Dr. Mathews and Dr. Dimah Saade mentioned too, kind of the ophthalmology evaluations and surveillance, and also addressing cognitive involvement, the brain involvement. But I think in general, it's important that local providers know that they're not alone. They have folks they can call, a friend, they can call someone who's in the field who can help guide them for complex questions.
Dimah, anything to add?
I think at least at our center, if you're have an available MDA clinic or muscular dystrophy association clinic, you tend to get multidisciplinary care based on your individual specific needs, and you sprinkle in surveillance through that. So a lot of that care is coordinated through your neuromuscular clinic and tailored to your individual needs. And then we partnered with primary care providers in the community for routine childhood things, getting a cold or routine surveillance, immunizations, and things like that.
Anybody else have anything? Carsten?
Yeah, I was just maybe posing a question to Dr. Kravitz to maybe comment on the challenges of pulmonary function surveillance in very young children and those with neurological impairment, so that they can't really follow the instructions of pulmonary function testing very well. Do you have some comments?
That's a very good question. A lot of children we follow with neuromuscular weaknesses, independent of the etiology, they're young and they cannot do pulmonary function tests. In a otherwise neuromuscularly strong patient, we can't do PFTs. Those are the breathing tests where we ask to blow out the amount of air in the lung and measure how much there is. We can't do that under 5, 6 years old. And then the more morbidities attached to the child, the more challenging it can become. But we can still get a lot of information. We can measure objectively oxygen saturations, especially when they're well versus sick, to give us an idea of how well the lungs are functioning. We can do carbon dioxide levels either by measuring it in the PFT lab or indirectly through serum bicarbonate levels. But for our younger kids, the best thing that we can do is take a very detailed history where we assess how effective the muscles are in producing a cough, in clearing secretions. Is there a reactive airway component that might be a confounding feature? What can they do? As a pulmonologist, I learn a lot just by talking to the parents while the child's in the exam room and watching what the child can or cannot do. And that will help guide me to ask questions that the parents can then flesh out how the family is living at home. So PFTs add a lot of value, but there's nothing that good old-fashioned history and physical exam can't help you with. And our pediatricians, our family practitioners, one of these children come in and they can be overwhelming, but there's still a lot of good basic pediatrics they can do to at least gather the information and then pass on to specialists and saying, this is what I'm seeing, what do I do?
And you may have the opportunity, some breathing tests or pulmonary function labs are trialing this SNP or the sniff nasal inspiratory pressure, where they put a little bit of a probe in the nostril. If the child cries, they can get a sense of the inspiratory pressure. So just if you see that in your local pulmonary function lab, that is another outcome measure. It's a little complicated we've tried it here at the NIH. It's a little bit complicated, but it may also be another metric for measuring pulmonary function strength.
Right. Well, I use a lot of times, and I think Kathy made mention of it. She said MEP, MIP, maximal expiratory pressure, maximal inspiratory pressure, or also a cough peak flow. And we entails putting a mask on the child's face and hopefully having them scream. And when they scream out, that measures the MEP. When they take the breath in to take the next scream, that measures the MIP. Looking at those numbers gives us an idea how strong the diaphragm is, how strong the chest wall muscles are. So we can take those numbers, but because they're very young, there may be a wide variance on how they do from breath to breath. So again, it goes back to a strong history with the numbers there, if we can get them, to guide us onto the next step.
So on the topic of pulmonary function, when do you feel like testing should be or evaluation should be started? How often? What are the indicators to begin breathing support? What are the factors to consider when cognitive impairment is present for those particular factors?
Well, depending on how severe the child is, I like to see the children at least twice a year, and if they're more problematic, up to 4 times a year. So I can keep a close tabs on them when they start to vary and change from the last visit, they haven't gone too far off the rails, so to speak, so I can then decide when I want to add that. I will do whatever type of PFT that child can do every visit I can. If they can't do anything, I'll just measure an oxygen and a CO2. Maybe they get a little older, oxygen, CO2, MIPS, MEPS. But again, I'm going back to talking with the parents. What did your child do at the last visit? What are they doing now? Has there been a change? And then when we start seeing muscle weakness related problems, parents say their cough is not as effective as it once was. They're starting to get colds and hold on to them. Then I have a lot of tools in my toolbox I can reach for. The most important piece of equipment is the maximal insufflator exsufflator, also known as the cough assist, which is a piece of equipment that can help augment the cough. It helps blow air into the lungs so that kids can take a bigger breath. And then it helps suck it out to mimic a cough. I mean, it's one of the few pieces of equipment we have that its title tells you what it does. It assists the cough. So we have that. But based on the history, we can decide if we need breathing treatments, bronchodilators, inhaled steroids. Not usually needed a lot in these type of children, but everyone's an individual, and some kids might get a benefit. Also, we're asking not just a lot of airway clearance questions. I'm asking about the child's sleep. These kids who have muscle weakness are at a higher risk for airway collapse while asleep. They're at higher risk for hypoventilation, which can mean they have obstructive apnea. They can have hypoxemia or low oxygen levels while asleep, or hypercarbia, high CO2 levels. And we have equipment that can help optimize their breathing while they're asleep. In particular, we use non-invasive ventilation through a BiPAP machine. For more severe kids, we may choose, with the parents' guidance, a tracheostomy and a mechanical ventilator. Again, titrating the therapy towards what each child or family wants and needs and can do. And then we can help them breathe better. We want them breathing well at night to allow for some degree of muscle rest so they can have a more effective and better quality of life the next day.
Great, thank you. So acute scenarios, when you're hitting urgent care or emergency department, what are the key facts that we need to make sure that providers are aware of in Dystroglycanopathies? Rich, we'll go with you again to start.
All right. Well, all us pulmonologists who take care of neuromuscular, we always tell our families are our best resource, because this is one child that you know so much about, and you go to the ER, they're not going to know much about these types of conditions. But you can guide them about, here's the things that are going on with my child. This is the things they need. Bring any equipment you have. If you have a cough assist machine, bring it with you. I can tell you, they're not going to have it at the vast majority of community hospitals. If they're on BiPAP, bring your BiPAP or bring your ventilator so that you can support your child while they're trying to do testing. You know, what test to emphasize for? Mostly they're going to probably need airway clearance, probably a chest x-ray, maybe some blood work to assess how well they're oxygenating and ventilating. If you have written instructions from your pulmonologist, bring them with you so the ER physician can look at the care plan and say, okay, I see what they're doing. They may not have expertise in your child's illness, but they do have experience in taking care of respiratory failure, of pneumonias, bronchitis, poor quality coughs. So that is in their wheelhouse. They can do these equipments, but as your child's advocate for them. Tell them this is what we need. Work with your pulmonologist back at your multidisciplinary center, if you're so lucky to belong one, and have a care plan written up going, hi, this is what you need to do for my kid. Let me help you with this. More doctors than not are going to at least hear you, and they'll see it. And if you have the phone number of your local pulmonologist, we're always willing to take calls from ERs 24/7 to help out, because we want to keep the kids at home, not in the hospital.
Can I mention one other acute thing that is unique to dystroglycanopathies, or not completely unique, but is particularly seen more in dystroglycanopathies, and that is acute muscle weakness in early childhood following a viral infection. So that's something that can occur in other children, but appears to be much more frequent in children with dystroglycanopathy. So the scenario that you get a viral infection, maybe you're recovering from that, but within the next 0 to 4 days, the child becomes profoundly weak. In that situation, there is some limited data that steroids, a short course of steroids might shorten the course of weakness. And so people should be aware if that occurs, you may need to, you should definitely go see your doctor and consider a short course burst of steroids.
Use your neuromuscular team. You know, they say it takes a village, but it's true. And we're here at Virginia and Iowa, the NIH, at St. Jude's. We're all over the country. You have a team, and even if you don't have one for your child because you live in a place where it's not accessible, reach out to Cure CMD, and they will put you in touch with a local provider who can help.
Maybe we should also address another potential complication in the alpha-dystroglycanopathies, and that is the heart. So some patients in the alpha-dystroglycanopathy group of disorders, not a lot, but some do have surprisingly progressive heart weakness, cardiomyopathy, even way beyond the muscle weakness would suggest. And so my question would be to Kathy and Dimah, in a large cohort of patients, how prevalent is this problem, and what type of monitoring do you recommend?
So thank you, Carsten. I totally agree. And Reghan said it, and Richard mentioned it too. I think that we do recommend, we assume that everybody with a dystroglycanopathy is at risk for cardiomyopathy. So we recommend at least annual monitoring. We have very good data on FKRP. We have less good data on the other dystroglycanopathies. I know maybe a third of our POMT1, POMT2 patients have cardiomyopathy. I think there are some other genotypes that we just don't have numbers to be able to say for sure. There may be some that don't, but we don't have that information, so it is prudent to always monitor.
What
Do you agree?
does screening for that look like?
In general, I think in this population, an echocardiogram is sufficient. Cardiac MRI is a possibility, depending on the patient. It may or may not require sedation. Given that with some diseases, we absolutely know that there is a cardiomyopathy, it will develop, and the cardiac MRI can pick it up early. In these diseases, I don't feel that we have that we don't know that as well. And I think I defer to the judgment of the local cardiologist and how comfortable their team is with sedating. We don't have, cardiac MRI is a powerful tool. I don't know that it has to be done on everybody with a dystroglycanopathy right now. I think we don't have the data, but others may have different opinions. And I know at Iowa, it's incredibly difficult to get into the cardiac MRI. It's hard to schedule.
How early would you suggest getting just a baseline echocardiogram?
At diagnosis.
Okay, so as soon as possible. Okay, great. Anything else we want to make sure that the ED or urgent care is aware of? Okay.
Well, there is the issue of seizure susceptibility in some of the alpha-dystroglycanopathies with central nervous system involvement.
Yep, we can talk about that right now if you like. How much of a concern is epilepsy and dystroglycanopathy? So that's seizures. So we use the term generally epilepsy, right? How do indications normally manifest? What steps are being taken, should we be taking to monitor or treat that? Dimah, you want to start?
Yeah. I think with congenital muscular dystrophy, especially when there's brain involvement, then that increases the risk of seizures. I don't know of an exact number, but that does increase the risk of seizures. What seizures can look like would depend on the age of your child and their motor ability. I think and their ability to interact as well. In children that are in infants or under a year of age, we often, during that time period, worry about infantile spasms that could be a manifestation. Rarely, though. I'm not saying that. I'm talking about the seizure manifestations that could occur based on age at different ages, depending on degree of brain involvement. But that's not a concern when you're much older. But what you're going to be looking for is in a clinical manifestation of a behavior under arrest or a sudden alteration in interaction. And if you're able to move, if there's slow rhythmic shaking that's not suppressible, or eye deviation that is stuck that you can't get them to get out of. But it's largely clinical, and I would say you talk to your neurologist about your specific child and what their age is, what are they at risk for, and how it could manifest with their motor abilities.
Okay.
It's perhaps also, as you all know, young children sometimes have a seizure with fever, and that can happen in the children with Alvarez Dystroglycanopathies also. So while the risk of developing epilepsy is higher in these children, on the first occurrence of that with fever, it doesn't mean it's epilepsy yet. So you need to be following with your child neurologist carefully to see that one captures this appropriately.
I just want to be clear, this is not something that everybody needs to be stressed out about at all. That we do know that this can happen, but this is not something that we're expecting for every child with dystroglycanopathy.
Okay. No, and exactly. And a one-time seizure doesn't mean that it's developing into epilepsy either. And so careful neurological surveillance will be the way to go.
Great.
So that is more frequent for the muscle-like brain disease.
Yeah, I mean, in a child where you know the underlying diagnosis, you obviously follow more carefully and to make sure there isn't something developing that would need treatment, obviously.
Okay. Let's talk about nutrition, diets, supplements. Overall, any recommendations, particularly for kiddos who are underweight, or just in general, what are the diet? Any specific diet recommendations? Reghan, I know you have a strong opinion on this.
Oh, I do? Okay. Maybe you can give me a hint about.
Well, just your stance is normal diet.
Normal diet. Oh no, thank you. Yes, that is our stance. And so obviously, if someone can eat by mouth well and swallow well, balanced diet is the best source of vitamins and minerals. For children that are fed via gastrostomy tube, I think working with a nutritionist are usually embedded in your muscular dystrophy multidisciplinary clinic, and they have such great knowledge about caloric needs and caloric intake and weight gain. And obviously, your child's going to follow their own curve, but having that input from a nutritionist is going to be really helpful to make sure you're getting maximal, nutritional input, and also for bone health, making sure you're getting vitamin D in sufficient quantities and calcium, very important for bone health, but also for the immune system.
Kathy, anything on diet?
I was going to say the same thing. Eat a normal, healthy, well-balanced diet as much as that is possible in a toddler, recognizing that things like children like toddlers don't often eat well-balanced, healthy diets, but don't freak out about it. Look at the growth curve with your pediatrician.
As long as there's some kind of a growth curve, it doesn't have to match what we call quote unquote normal growth curve. But as long as there's some kind of a growth curve, that's the goal, right? Okay. Thoughts on steroid therapy? There are anecdotally in the dystroglycanopathy community, people are taking steroids every 2 to 3 days, maybe once a week. Any thoughts on that? Kathy?
I think for people with more slowly progressive disease, the risks of steroids outweigh the benefits.
What are the risks?
The risks are weight gain, osteoporosis, hypertension. Those are probably the biggest. Glaucoma, cataracts, the other eye thing. So there are significant risks of daily steroids. The option of intermittent steroids are unproven in this group of diseases. The risks are lower. I would discuss it one-on-one with your neurologist, and if you want to do intermittent steroids, have a very clear way of monitoring what the progress has been to date and what the progress is after steroids, and monitor closely for side effects because we don't have data.
That covers my care questions. Gus, I would like you to go back to the research question on other research underway before we close, because that kind of addresses one of the questions in the chat.
Oh, yeah. Yeah, it was a more general question. We talk about gene therapy and we talk about the sugars supplementation, sugar precursor supplementation as Ribitol. People is asking if there is any other treatment development underway that you know of and you can comment, or any early research that you think is important to generate hypotheses for therapeutic ideas?
I'll just make a comment that this is a time in our lives in the world that there is a lot of progress being made in muscular dystrophies. Some of those therapies that are being developed for other muscular dystrophies are specific to a given gene. If you replace dystrophin for somebody who's lacking POMT1, you are not going to benefit them. So some of them are gene-specific therapies, but some of them are not gene-specific. They address the underlying pathophysiology of what happens when there is a muscle disease and often a cardiomyopathy. So there are some exciting things being developed in other kinds of muscular dystrophy that, if they are shown to be effective and become approved, could very well, by pathophysiology, be beneficial to people with dystroglycanopathies, including the congenital muscular dystrophies. So I think there are some exciting things happening in the world of muscular dystrophy therapy. And we need to keep our eyes on that and celebrate all the successes that we see.
Yeah, thank you for that, and for the audience to know, we all participate in the international meetings, FDA, World Muscle Society, that we learn from each other, from the different type of muscle disorders.
Science is not happening in a vacuum. You guys are collaborating, which is good to know. All right. Well, thank you very much, everybody. I'm grateful for your time today, and I'm quite sure that our dystrophy community is also grateful. So keep doing what you're doing. We appreciate you, and have a great rest of your weekend.
Thank you. Bye-bye.
Bye-bye.
Thank you. Bye.